Thank you, Radik, and good afternoon to everyone. First of all, let me thank the organizers of the meeting for inviting me and to discuss about the genetic basis of MDS. And I don't have any conflict of interest to disclose. And according to our current understanding, myelodysplastic syndromes arise as a consequence of one or more somatic mutations that occur in a hematopoietic stem cell and confer to the cell a proliferative advantage, leading to the expansion of the clone. And in addition, other factors interacting with the hematopoietic stem cell, including bone marrow microenvironment and the immune system, may contribute to the selection of these clones and to promote their expansion and progression. And it is usually at the stage of a largely or fully dominant hematopoietic clone that the disease becomes clinically evident as a consequence of the ineffective differentiation and maturation induced by the same mutations that are providing the proliferative advantage or by additional cooperating mutations. And in the last few years, the genetic lesions involved in this process have been largely clarified. And besides the well-known chromosomal abnormalities, mainly deletions identified by conventional cytogenetics, somatic mutations in more than 40 genes have been identified. But notably, only 5 to 6 genes are consistently mutated in a high fraction of patients. And these genes are mainly involved in two biological processes that are RNA splicing and epigenetic regulation. And notably, by deriving the temporal order of occurrence of these mutations during disease ontogeny, by analyzing the allele frequency obtained by sequencing data, the most frequently mutated genes are also those that usually occur earlier in the natural history of the disease. But the emerging evidence is suggesting that mutations in splicing factors or epigenetic regulations may have a significantly different role in the pathophysiology of the disease. And in fact, if we look at the distribution of these mutated genes across myeloid neoplasms, we can see that mutations in splicing factors are rather selectively associated with the myelodysplastic process, whereas mutations in epigenetic regulators occur equally across MDS or myeloproliferative neoplasm or acute myeloid leukemia, suggesting that these mutations may be early common pathogenetic events in the pathophysiology of myeloid neoplasms and fostering the hypothesis that these mutations may occur upon aging. And in 2012, the group of Ross Levine in New York first provided the evidence of somatic mutations in TET2 in otherwise healthy elderly subjects with clonal hematopoiesis, as demonstrated by X chromosome inactivation pattern. And later on, 3 large population-based studies provided consistent evidence of hematopoietic clones arising upon aging in elderly subjects with otherwise normal hematopoietic system. And as you can see, these mutations are rather rare before 50 years of age, while tend to linearly increase after this threshold, rising up to 20% of prevalence in subjects 70 years or older. And these hematopoietic clones are associated with a significantly higher risk of developing hematopoietic neoplasms in the following years. And looking at the mutated genes that are involved in this process, as you can see, all these genes were previously described as recurrently mutated in myeloid neoplasms, but in particular, these hematopoietic clones are driven by mutations in 3 genes that are DNMT3A, ASXL1, and TET2. And if we look at the number of somatic mutations in subjects with these age-related hematopoietic clones, we can clearly show that most of these patients, of these subjects better, have only 1 mutation in the set of the analyzed genes. Whereas if we look at patients receiving a diagnosis of myelodysplastic syndromes, at the time of diagnosis, these patients have usually 2 or more somatic mutations. So suggesting that subjects with these age-related hematopoietic clones may have acquired the first genetic event that is driving the expansion of a hematopoietic clone without any hematologic phenotype. And if we look at the size of this hematopoietic clone, again we can realize that subjects with these age-related hematopoietic clones has usually a variant allele frequency up to 10%, whereas patients receiving a diagnosis of MDS at the time of diagnosis have a clone that is usually consistent with fully dominant or largely dominant hematopoietic clones with a variant allele frequency of 40 to 50%. And so, based on this observation, the following pathophysiological model can be assumed, in which, upon aging, a first genetic event may be acquired, usually involving genes in epigenetic regulations that drive the expansion of hematopoietic clones at this stage without any hematologic phenotype. And then the occurrence of additional cooperating mutations is required to transform the cells and to drive the expansion of the neoplastic clone. And it is this second genetic hit that is determining the type of neoplasm that is arising. If, for instance, mutations in genes involved in RNA splicing is occurring, an MDS is developing, a gene involved in signal transduction such as JAK2 or MPL, a myeloproliferative neoplasm may arise, while if an NPM1 mutation is then occurring, an AML is developing. So the founding clone, the founding mutations driving the expansion of the age-related clone is not determining the disease phenotype, the cancer phenotype, but may modulate its clinical phenotype. And in fact, we previously shown that the presence of mutations in TET2, DNMT3A, ASXL1, or EZH2 are invariably associated with a multilineage dysplasia in MDS. And this was recognized by hierarchical clustering analysis, recognizes these mutations as one of the most relevant classification criteria. And the same applies in MDS associated with SF3B1 mutations, in which precedent mutations in TET2 or DNMT3A are invariably associated with a disease phenotype characterized by ring sideroblast but multilineage dysplasia as well. But other genetic lesions are associated in MDS, or more specifically associated with disease phenotype, suggesting that they may be disease-defining. And the paradigm in MDS is offered by the 5q- syndrome, that, as you know, was first described in the early 70s by Van den Berg, and the deletion of the long arm of chromosome 5 is associated with a rather specific clinical phenotype characterized by a normal to high platelet count and a very favorable prognosis. And the pathophysiology of this specific subset of MDS has been clarified by using a systematic approach of RNA interference in hematopoietic cells. And this approach provide the evidence that the disease is sustained by the haploinsufficiency of selected genes mapping in the common deleted region in the long arm of chromosome 5. And in particular, the haploinsufficiency of RPS14 is responsible for the erythropoietic insufficiency, resulting in an increased expression of p53 and in an increased apoptosis of erythroid progenitors. Whereas the haploinsufficiency of 2 microRNA mapping in the common deleted regions and involved in the regulation of innate immune system are responsible for the megakaryocyte abnormalities and the high platelet count. And finally, the haploinsufficiency of this casein kinase 1A1 is responsible for providing the clone with a proliferative advantage. And several lines of evidence suggest that the deletion of 5q may be the lesion responsible for the disease and may be the only genetic lesions required to promote these MDS subtypes. And in fact, the experiment of genotyping of a single hematopoietic stem cell we conduct in collaboration with Peter Voll show that in a large proportion of cases, the deletion of 5q is the only genetic lesions that can be observed in patients with the 5q minus syndromes, and in most cases, the deletion is preceding recurrent mutations in low or intermediate risk MDS. But nonetheless, this deletion may occur on the background of an age-related hematopoietic clone. And the identification of the molecular basis also provide the evidence for a targeted treatment, and we know that the lenalidomide has a selective activity against the 5q minus clone, as it was recently shown that this agent is inducing a degradation of proteins by increasing their ubiquitination, and in particular is increasing the degradation of the casein kinase 1A1, that is the basis for the proliferative advantage of the 5q minus clone. And therefore, the 5q minus clone that is haploinsufficient for this protein is more vulnerable to the effect of the drug compared to the normal hematopoietic stem cells. And other genetic abnormalities were recognized as MDS defining. These chromosomal abnormalities were acknowledged by the WHO classification as providing a presumptive evidence of MDS, even in the absence of an overt bone marrow dysplasia. And although these cases are rather rare and usually account for no more than 5% of the low-risk MDS, according to the data of the AUM MDS registry, they provide a proof of concept that identifying genetic lesions that are specifically associated with the myelodysplastic process may provide the basis for diagnosis and MDS on a genetic basis without the need of a clear evidence of bone marrow dysplasia. And another lesion that is markedly associated with a disease phenotype in MDS is the somatic mutations of SF3B1. And in 2011, within the International Cancer Genome Consortium, we identified these mutations in patients with MDS and ring sideroblast. But the association of the mutations with ring sideroblast is even higher than initially suggested by the association with the sideroblastic categories. And in fact, ring sideroblast can be found also in other MDS subtypes not identified and classified based on these categories, for instance, the 5q minus syndromes or the MDS with excess blasts. In addition, as you know, the WHO classification first introduced a threshold of 15% of ring sideroblasts to classify an MDS within a sideroblastic category. But other MDS classified as refractory anemia or refractory cytopenia with multilinear dysplasia may show a percentage of ring sideroblasts between 1 and 14 and 15%. So when accounting for all these cases, we found that the mutation in SF3B1 has a positive predictive value for ring sideroblast of nearly 100%. And notably, the mutation was also found in a fraction of patients showing less than 15% ring sideroblast, suggesting that this threshold is probably arbitrary and is not identifying a specific biological process. And again, several lines of evidence are suggesting that these mutations is founding mutations of the MDS clone, and this comes from the analysis of variant allele frequency, showing that the mutation usually has an allele burden of 40 to 50%, suggesting that maybe the founding event of the MDS clone. And in most cases, the mutations precede other somatic mutations in MDS with ring sideroblast. And finally, interesting, in about 40 to 50% of patients with MDS receiving a diagnosis of SF3B1 mutated MDS, the mutation in SF3B1 is the only somatic mutations that can be detected at the time of diagnosis with a comprehensive gene targeted sequencing, suggesting that the mutations may be able to promote the transformation of the hematopoietic cells without the need of co-occurring, cooperating mutations. And this is consistent with the biological effect of the mutations in cell. And in fact, it was shown that mutations in these splicing factors is inducing the recognition of cryptic 3' splice sites that in turn is resulting in a frame shift and in the introduction of stop codons. And this abnormal RNA may either undergoing degradation, resulting in a non-classical path to haploinsufficiency, or may be translated into aberrant proteins. So single mutations at the DNA level in SF3B1 mutated genes may result in abnormalities in several genes, thus disturbing several pathways within the mutated cells. And at odds with TET2 or the NMT3A mutations that tend to increase linearly during aging, SF3B1 mutations were shown to appear selectively in subjects 70 years older, suggesting that this could be one of the cases in which bone marrow microenvironment abnormalities related to aging may concur to promoting the selection and the expansion of these clones. And the mutations also have relevant clinical implications. In fact, if we look at the disease phenotype, we can find that SF3B1 is identifying a very homogeneous subset of patients with isolated erythroid dysplasia. And looking at the prognostic value, patients carrying SF3B1 mutations has a significantly better prognosis compared to other patients. And the same effect was observed within MDS with ring sideroblast. And by applying hierarchical clustering analysis, we shown that the mutation is recognized as one of the most relevant classification criteria in MDS. And based on this and other observation, the recent revision of the WHO classifications introduced SF3B1 as one of the co-criteria for the MDS with ring sideroblast, and in the presence of the mutations, 5% of more ring sideroblasts are required to classify the patients in the sideroblastic category. And the mutations is also affecting the clinical outcome and phenotype. And in fact, again, we demonstrated that the mutations is associated with a largely ineffective erythropoiesis, resulting in a suppression of hepcidin and an increase in iron absorption and recirculating, and in a more severe iron overload. And more recently, the GDF11 inhibitors were found to be selectively interfere with the process of ineffective erythropoiesis. And GDF11 inhibitors were then tested in clinical conditions characterized by ineffective erythropoiesis, including MDS. And the phase 2 studies showed that in MDS, the significantly higher frequency of response was observed in patients with SF3B1 mutations and ring sideroblasts, suggesting again that ineffective erythropoiesis is one of the most relevant pathophysiologic effects of the mutations. And finally, the inhibitors of splicing were previously known, and these agents were tested in a cellular and mouse model carrying a mutation in SF3B1 or SRSF2. And interestingly, the cells carrying the mutations show higher sensitivity to the inhibition of the splicing modulators, suggesting that these agents could have a clinical effect, and indeed a phase 1 studies has recently been launched in the US. Finally, we explore whether somatic mutations could have implication on the classification of myeloid neoplasm as the cytogenetic abnormalities were shown. And to this purpose, we analyze a consecutive cohort of patients with unexplained cytopenia or anemia, and a fraction of them were diagnosed as ICOS, that means of idiopathic cytopenia of undetermined significance. And these patients show about a 50% probability of developing a myeloid neoplasm in the following month. But if we look this risk according to the mutation status, we found that this probability is significantly higher in patients carrying mutations, and we were able to recognize a subset of these mutations, including splicing factors, have a commutation pattern of TET2, the MNT3A, and the ZXL1 that were highly specific for MDS. And looking at the clinical outcome of patients with these mutations, having a diagnosis of MDS or of ICOS, there was no difference in the clinical outcome, suggesting that these mutations are probably candidate to provide evidence of MDS irrespective of the presence of bone marrow dysplasia. So just to conclude, we are able now to identify distinct patterns of somatic mutations in MDS, one age-related and one MDS-specific. Gene haploid sufficiency is a recurrent mechanism in these somatic mutations, and identification of mutations specifically associated with the MDS process may provide the basis for a genetic classification of this neoplasm. And thank you for your attention.